Hello, and a very warm welcome to all of you joining us live today for our first MyAware webinar of 2025. Before we begin, let me just introduce myself. Some of you may have seen me before at other Zooms. My name is Laura, and I'm one of our national support coordinators, and I will be our host today for today's webinar. You may also see that I'm also joined by our guest speaker, the fantastic Charlotte. She's also another member of the team here at MyAware. Charlotte is our Research and Partnerships Manager, and as many of you will know, one of her many important roles here is supporting you with your questions on all things myasthenia research. She certainly is an invaluable asset to our charity, and she has been with us since 2022. Quite frankly, at this point, if Charlotte doesn't know it about myasthenia, it might not be worth knowing. Today's webinar is on lung and bone health, and we've selected this to kick off the year after many of you have answered our research survey and stated that this is a topic that you would like to learn more about. So thank you for that. We are very fortunate today that Charlotte has spent her time and expertise tailoring this webinar to benefit all of the types of myasthenia. And I'm certainly sure that we will all take away some new and helpful knowledge on this subject. So thank you, Charlotte.
No problem.
Before we begin, we just wanted to remind you that we will be recording today's webinar, and we will update you all as soon as the recording goes live onto the website. We know that many of you will have some questions about the topics we're covering today, and if you do, please submit them using the question and answers tab, which should be available on your screens. Charlotte will kindly be reviewing all of those questions and will be sharing the answers with you in the coming weeks when the webinar goes live onto the website. Just a very quick reminder that we, of course, won't be able to answer any questions that are specific to your health, such as should you change or start a new treatment. We would kindly ask you to contact your healthcare provider for those. If you would like to, you can turn on subtitles for our webinar under closed captions, and you can also change the language should you need to. If you are going to use the closed captions, do remember that Zoom doesn't always get those words quite right, especially words like myasthenia it might not have heard very much before. So if you do have any questions or you weren't quite sure about the content today, do remember that you can contact us afterwards on the support email, which is support@myaware.org. So without any further ado, I will hand over to you, Charlotte, and I will see you all at the end of this presentation.
Okay, so hi everybody, and thank you, Laura, for that very kind and ego-inflating introduction. We'll be very lucky if my head can fit in the webcam by the time we finish this up. But yeah, as Laura said, my name is Charlotte, and I have the great pleasure in being the Research and Partnerships Manager here at myAware. Now, before we get started, if I can just change slide, here we go. Always good start. I just wanted to cover a few key points about the webinar today. First of all, as I said, welcome and thank you for taking your time out to come and attend the webinar today. As Laura said, this webinar topic was chosen by the members, and it's great that so many of you are here today to listen in. It's really appreciated. I know that it's not the easiest thing just to stop what you're doing during the day if you've got plans and come and sit on a Zoom call. But yeah, the fact that you're here means that you have a great interest in myasthenic research, as do I. So thank you for being here. Secondly, as Laura said, I want this to kind of be a learning experience as best as possible. There will be no test, which is probably of great relief to everybody. I'm trying my best to make this webinar as accessible as possible. And what I mean by that is that hopefully everybody should be able to take home a few messages or a few new bits of info, regardless of whether it's been 50 years since your last science lesson or if you're even working in a lab right now. And of course, there are no silly questions. And as Laura mentioned, feel free to get any that you may have into the chat, and the support team will collect them. I'll work through them and try and get basically a resource sheet out to you all as soon as possible, answering all those questions or clearing up any topics that I might not have explained too well today. And while we're on the topic of the support team, I wanted to thank the lovely Laura and Anna who are working behind the scenes to give me some much needed help today. They have been working really hard in the run up to this webinar, and I could not do it without them. So thank you very much. You're both wonderful, and now you can have a big head like me. And finally, a quick disclaimer about me, just so people are assured that I somewhat know what I'm talking about. I was a scientist before coming to myAware. I studied genetics at university, and then I worked a little bit in cancer research before starting my PhD in medical imaging. So hopefully I'm able to understand research a little bit and break it down into sort of more understandable ways for folk if you don't have too scientific a background. But if not, and I'm not making any sense, please feel free to let us know in the feedback. I'm always open to constructive criticism and getting better at that. You can also probably tell that I'm Scottish and even more so Glaswegian. We have a tendency to talk fast, and I'm going to try my best to make a concentrated effort to speak a little slower than I normally would, especially when I'm nervous. So I do apologise if I slip into any scientific jargon or go off track a little. I'll try my best to cover these things up in the FAQs. So here we have a little summary slide, which is littered with spoilers about what I'm going to discuss today, just so you have a feel for what the webinar will be about. It might also give you a clue of when to go for a strategic tea or bathroom break, if there's something there that you really don't want to know about. So we're going to have what I think is a nice journey through the biology of lungs and bones, set up a little foundation of knowledge that we can build upon. Then we're going to look at an overview of the myasthenias so that we understand how the two topics play together. And then we'll look at more specific topics on lung and bone health, and of course, a little peek at some of the recent literature that has been published and research that's been done on that topic in particular. Now, as I find myself saying, unfortunately, quite often, with myasthenia being a rare disease, it can often be difficult to find examples of the research that you're trying to learn more about. And simply that is because it might not have been done yet. And with that in mind, I did notice that while studying for this webinar, there's certainly been an increase in research within the past 10 years or so, which is really encouraging to see. And as we go through this webinar, I'll pick out a few topics that I think hopefully will receive a bit more attention as time goes on. So without further ado, let's get started. As I said, I want this webinar to be as accessible as possible and open for learning. So we're going to start with a little background biology that I feel is going to lay a nice foundation for some of the more complex topics and pieces that we'll look at a little later on. We're going to start with bones, basically, and what they're made of. This will be important as later on we're going to talk about things such as bone fractures and bone density. So this will give us a little bit of insight on how this plays into myasthenia and the research that we're going to talk about a little later. Bones are composed of layers, basically, of differing strength and composition. And I'll get my little laser pointer to help me out. It has this, first of all, dense outer layer, which is called the compact or cortical bone, and it provides strength. So you can see that here in the diagram. It also has a spongy layer, or a spongy bone, called the trabecular bone, which is porous. You think a little bit like honeycomb almost on the inside. And what this does is it makes bones lighter and lets them store bone marrow, which we all might know a little bit about. And the bone marrow itself is in the cavity, the marrow cavity, helpfully named. And it's this hollow space for bones, and it produces blood cells and stores fat. Now, if we zoom in a little bit on the compact bone, this outer layer, we can see that it's organized in these little systems, like little building blocks called osteons. And what they do is they contain nerves and blood vessels. And as we can also see from the diagram, it is this cylindrical shape. And what this does is it helps the compact bone withstand stress and strain, providing strength and stability. So if we take a closer look at bone marrow in particular, it plays a key role in the function of our immune system and can therefore be linked up with myasthenia gravis and Lambert-Eaton myasthenic syndrome from an autoimmune perspective. Bone marrow is responsible for producing B cells, which once they've grown up and matured a little, can travel to tissues such as our spleen or our lymph nodes and produce antibodies, which help us fight infection. We'll recap the role of antibodies in myasthenia quite shortly. T cells are also produced by the bone marrow, but they are matured at the thymus, which in itself is directly associated with myasthenia treatment through its removal in a process called thymectomy, which some of us today may have already had. T cells play a role in activating B cells to produce antibodies and coordinate the body's attack on infected, cancerous, or foreign materials. Now, it would be a little remiss of me to hold a webinar entitled Bone Health and Lung Function and not actually discuss the function of lungs. So for the sake of tying this into myasthenia, we're going to specifically talk about the muscles involved in breathing. And as I talk, you're probably going to feel yourself acutely aware of your own breathing, which normally we do it without even thinking about. But when we are talking about muscles involved in breathing, when we breathe, signals are sent to these particular muscles around the lungs, and they flatten the diaphragm, which is that kind of sheet layer just below the ribs, and the intercostal muscles, which are basically the muscles in between your ribs. And if anybody ever orders spare ribs when they go to a Chinese restaurant, that's what you're having, intercostal muscle. They contract. And by contracting these intercostal muscles or spare ribs, the body creates more space for your lungs to expand and take in your breath. And the air you breathe is then split between these branches that we can see here as it comes down. It goes out and down into two into each lung, and they're called the bronchi. And if you tilt your head a little bit, you can see it kind of works a bit like an upside down tree. And this makes even more sense because the branches of the bronchi then split off into thousands of other branches, smaller branches called bronchioles. And if you zoom in a little into the bronchiole, we can see that they end in these little air sacs called alveoli, not ravioli, as I mistakenly called it for a good chunk of my university education. So the alveoli themselves contain oxygen. And basically what they do is when we breathe in and we take in oxygen, the oxygen in the air sacs then swaps out with the little, you can see blood vessels here, capillaries, and allows the oxygen to go into the bloodstream and go around our body. The carbon dioxide that it pushes back out then comes back up, basically through where the oxygen should come, and we exhale. And it all comes through this tree-like network, again, with the help of a contraction and relaxation of our diaphragm, which balls up, and the intercostal muscles, which relax. So you wouldn't probably think about it, but our lungs inhale and exhale an average of 25 times a minute, and we half the time don't even realize until you specifically start talking about breathing, and it's the only thing you can think about. Now, I did say there wouldn't be a test, and I stand by that. But what I thought might be a little helpful is a little vocabulary check of some phrases or words that will come up or might even have already come up. And it's up to yourselves. If you want to take part, you can take note of these 7 keywords. We've got bone mineral density, or BMD, bronchioles, which we've already discussed, the intercostal muscles, or the spare ribs, as we've already talked about. But there's also words like calcium channel and neuromuscular junction and B cells and osteoporosis. So keep those in the back of your mind as we go through, and I'll bring up this list again at the end of the webinar, and you can see if you can remember, oh, what does that mean? I think I know what that means. And hopefully we can take home a few wee messages and some new things that we've learned. Every day is a school day, as they say. Now, I'm going to do a quick recap of the myasthenias and how they work so that we're all on the same page. This picture here should hopefully look a little familiar to you, especially if you've been on the MyAware website or watched our video during Myasthenia Awareness Month. But if not, don't worry, we're going to go through it step by step. What we see here is called the neuromuscular junction, and it's a space in the body where nerves communicate with muscle cells. So nerves pass messages to muscles, like we discussed with breathing, instructing them to contract or relax to carry out different functions all around the body. And if we look at these little bubbles within the nerve cell, we can see that there's these small red spheres. And what they represent are neurotransmitters, which is a fancy clinical term for a messenger, particularly a chemical messenger. And in this case, this one is called acetylcholine, which might ring a few bells with people here today. And basically, what acetylcholine does is it acts as a messenger, or even like a little postman between your nerve and your muscle cell, telling it that the nerve wants you to contract or the nerve wants you to relax. So let's put this into the context of the myasthenias. First of all, starting with myasthenia gravis, and then we'll talk about LEMS and congenital myasthenia. So we're back here with our neuromuscular junction, and we're going to have a little animation that shows how this works in someone without myasthenia first, so we can see the comparison. So the nerve needs to get a message to the muscle, so it releases acetylcholine, and that binds to the receptor on the muscle, and the message is heard loud and clear. The muscle contracts or relaxes, whatever it needs to do, and everything goes smoothly. In the case of myasthenia gravis, antibodies, which we know are produced by B cells, which comes from the bone marrow, they bind up and block the receptor on the muscle cell, meaning that when acetylcholine is released and comes along, it is unable to bind, as we see here, and it floats away, and the message isn't received. And this sort of process in an MG patient is represented or symptomatic of muscle fatigue. So whenever you're feeling a fatigue in your muscles, if you were to zoom down super duper close within your body, you would see this process undergoing, if in particular you have that type of myasthenia gravis. Now, what about Lambert-Eaton myasthenic syndrome, and how does that work? So in this case, we're going to again look at someone without LEMS first, and I'm going to add one little piece extra to the process that I didn't cover with MG, but it all works the same. You'll see here that we've got this turquoise structure on the outside of the nerve cell. This is called a calcium channel, and as the name suggests, what it does is it will bind calcium and signal to the nerve that it's okay, it needs to release acetylcholine and get that message shared with the muscle. And then we get our signal passed from nerve to muscle. We have contraction or relaxation, just like previously discussed, and all works well in theory. For someone with LEMS, however, this calcium channel is, similarly to MG, blocked up by an antibody. And this, again, as you can see, is kind of similar to what we saw with the acetylcholine receptor in MG. And like MG, it means that the receptor is blocked up and calcium can't bind. And what this means is that the nerve doesn't know to release acetylcholine or release its chemical messenger, meaning it stays closed. And then again, this results in the nerve and the muscle not being able to communicate and leads to the muscle fatigue that we see in LEMS. Now, last but very much not least, we have congenital myasthenic syndromes. And we're going to take a closer look at them. This one might look a little bit more complicated as we get into it, but the key message to remember is that unlike LEMS and MG, we're not thinking about antibodies or the immune response, but rather we're focusing on genes. Now, genes can help our body coordinate the expression and regulation of proteins, which act kind of like building blocks to different structures within our body. They can help with the expression of hormones and all sorts of stuff. They play a number of roles, and basically they're named after a process that they help out with, or might in some cases mitigate the response. Now we'll be able to see here, we can see a few familiar players, and we actually find that a number of the genes associated with CMS are affecting structures we know play a role in LEMS and MG. So if you look at that CACNA1, that's another thing about scientists, is that they never name anything with a simple name. It's always something complicated. But with this CACNA1, it affects the function of calcium channels. So you can understand a bit about how that would impact someone's ability to communicate their nerves to their muscles. Or if we look at the CHRNE gene, which has a number of different genes associated with this sort of family, and it has a role in acetylcholine function. So again, affecting the way that acetylcholine works. In CMS, a patient will have at least one of these faulty genes, meaning that they aren't working the way they should. And this in turn affects the process of communication between nerves and muscles, again, leading to muscle fatigue. Now, moving a little bit on to research, now that we've got this nice foundation of knowledge and we're all feeling a little bit maybe more understanding about how myasthenia works. If we're talking about lung function, I think one of the best things we can talk about is respiration and how the role that plays in myasthenia. We're going to look at myasthenia gravis first and then look at LEMS and CMS. We know that a number of myasthenia patients report shortness of breath. And in fact, as we can see from the table below, breathing is a scoring component when clinicians assess the severity of one's myasthenia. And this system that they use in particular is called the MG-ADL system, which might be similar or might be familiar to some of you. It stands for myasthenia gravis activities of daily living. And basically what it does is puts a numerical value on one's myasthenia that helps classify how severe their disease is, depending on how it impacts different factors such as breathing or chewing or swallowing, a number of different factors. It also helps prioritize patients when opportunities for clinical trials arise. And there are 8 criteria which are scored from 0 to 3, depending on the degree of severity. With this in mind, the MG-ADL score of a patient can be anywhere between 0 to 24, with 24 dictating the most severe cases. It's my understanding that the scoring system can also be used to assess CMS and LEMS, but that's only because at the moment there lacks a specific scoring system for these diseases, and this is an area of research that needs attention. Something that concerns breathing in myasthenia is anesthesia and how this affects the quality of peri and post-operative care for patients. Most of us will be aware that great care needs to be taken for myasthenic patients who require general anesthetic. But how does anesthetic work and why can it be contraindicated in myasthenia? Well, I have a handy little diagram here developed by the Okinawa Institute of Science and Technology. And if you think this looks a little familiar, you'd be very much correct. We're looking at another neuromuscular junction, and it's just a little bit more detailed than the one I showed previously, but the steps are all the same. We're seeing a signal come down through the nerve, telling the calcium channel to open, triggering the nerve's release of acetylcholine. And look, they even stole my red spheres. So as you can tell, great minds think alike. And we see acetylcholine passing through onto the muscle cell to send on its message. But we've got this all down pat. We're confident with this topic. And the reason that we need to take great care in using anesthesia as a myasthenia patient is that the method through which anesthesia works, in that it tries to relax the muscles, can exacerbate the fatigue that is brought on by myasthenia. If myasthenia is affecting the diaphragm or other respiratory muscles, like the ones we discussed previously, like the intercostal muscles, i.e. spare ribs, anesthetics can depress the central nervous system and cause muscle weakness that further compromises breathing, increasing the risk of respiratory failure. With this in mind, it's really important that your care is looked over by a team of experts that includes an anesthesiologist before undergoing surgery. Looking specifically at LEMS, and as I mentioned at the top of the webinar, there's not a whole lot of research with regards specifically to respiration in LEMS. Understandably, a lot of conclusions that are drawn from MG research will be applied to LEMS. And what I did find is that respiratory involvement is reported to be around 16% of LEMS patients, and it's usually mild with a restrictive functional pattern. And what this basically means is that it's rare for it to be involved in someone's LEMS, according to the study, but it can be complicated by other diseases such as COPD, increasing the risk of respiratory failure occurring. However, mentioning that study, the primary one that I could find was published in 1989. So, as I said at the beginning of the webinar, there remains a great need for more modern and further assessment of respiration involvement in LEMS patients. As discussed in the CMS roundup, congenital myasthenic syndromes are caused by faulty genes, which are involved in the process of neurotransmission, which is a fancy clinical term that describes communication between our nerves and cells, nerves and muscle cells, sorry. I have a list of genes here which are involved in CMS or associated with CMS. Mutation or incorrect regulation of these genes that I've underlined in red in particular have been noted to play a role in breathing impairments, particularly in the early stages and critically in terms of at the point of birth. As we can see with the progression of someone with the COL13A gene, with a mutation within that gene, breathing and feeding difficulties are one of the first symptoms to feature and must be cared for appropriately. The next slide covers the topic of myasthenic crisis, which, as we know, crucially involves the respiration system. This crisis is an exacerbation of the muscle weakness, specifically targeting the bulbar muscles, which play a role in controlling breathing and swallowing. This can occur with those with MG, LEMS, or CMS and requires immediate medical intervention, often in an intensive care setting. Now, where research is currently on this topic is that there's some studies being undertaken that compare the benefits of invasive versus non-invasive mechanical ventilation. As the name suggests, non-invasive mechanical ventilation provides some of the breathing support of invasive without the added risk of infection and other complications associated with endotracheal or tracheostomy tubes. Time will tell, though, if our practices begin to adapt to incorporate non-invasive methods or invasive approaches over invasive approaches. And speaking of ongoing research, I found a study which was published last year, specifically looking at the burden of breathing, fatigue, sleep, mental health, discomfort, and usual activities of MG patients compared to the general population. Now, we may be asking, why is research like this important? Surely it's well known that there is a significant burden with these activities when associated with MG patients. And it may feel like common sense, and to this community it is, but with the recent discussions regarding new therapeutics and the unmet need of myasthenia patients in the world, it has highlighted that there remains a significant lack of awareness of the disease and its impact on patients. Papers like these are crucially important to creating literature precedents on these topics and growing the global understanding of myasthenia. This study in particular utilized the My Real World MG database, which collected patient data from numerous countries, including the UK, such as demographics, treatments, and scoring on a variety of symptom scales, including the MG ADL scoring system that we discussed previously. And what they found when looking at these activities, particularly in breathing, is that there is a comparable difference in the breathing burden between the 1,300 or so patients who answered questions on their own breathing experiences when compared to the general population. We can see that a 51% of MG patients who took part in this study reported a shortness of breath with exertion, which is more than double that of the 20.1% of the general population who report the same burden. Indeed, this data also shows that more severe side effects or severe sides of breathing problems is more common amongst myasthenia gravis patients when compared to the general pop. And if I haven't said before, please feel free to take note of these publications. This one in particular is the author is De Wilde et al., which just means there's more authors, and it was published in 2024. And feel free to have a read through yourself. I'm happy to talk through these findings with anyone who would appreciate a discussion. As Laura mentioned, we're planning to upload basically a help sheet with answers to all the questions that you have. And on top of that, I'm going to put in a little bibliography, which will have all the papers that I've used to make this webinar and their PDFs so that you can download for yourself, read in your own time, and feel free just to get in touch with me and we can talk about any of them if you have any questions. So hopefully that should be of use and it'll be up on the website as soon as we can get it going. Now this paper is a little bit more clinically focused, but we're going to go through it together, so don't worry. This group in particular looked to explore the relationship between inflammation markers. And what inflammation is it basically acts as a little bit of like a flag for your body to show that there's an infection or that the immune system is required at a specific site. So you think about if you get a fever or if you have a cut and you know it's around the cut that the skin goes a little bit pink or red. These are inflammation markers because it's telling your body over here we need, B cells or we need white blood cells, clotting factors, something here to help fix and fix the skin, reduce our risk of infection. And that's it. That's a long and short way of describing what inflammation does. And what this group wants to do is take these inflammation markers and see if there is a relationship between them and clinical activity, respiratory failure, and prognosis in MG patients. And what they found is that they looked at 120 control participants, which were people without MG, and they compared their data to the MG patient data. And what they found was that, the inflammation markers are easily measurable for clinicians. They're available in MG patients and they're cost effective as parameters for abnormal expression in MG patients. And in particular, as this graph shows, that compared to the reference line, which will probably just be like a standard way that we can look at breathing difficulties in MG patients or clinical activity, that this particular inflammation marker called PLR, which stands for platelet to lymphocyte ratio, is a plausible marker, an independent predictor of respiratory failure. The platelet to lymphocyte ratio is a blood test that patients can undergo. And what it does is it measures, as the name suggests, the ratio of platelets that you have. And what platelets are is clotting factors, basically, in the blood to lymphocytes, which are a fancier term for your white blood cells. And they help us fight infection. So as we discussed previously, B and T cells, they are also regarded as lymphocytes. So things are all starting to connect a little bit from our earlier slides into the research that we're talking about, hopefully. And finally, the last study that we're going to look at in terms of lung function and respiratory research in myasthenia is this paper here, which comes from a group in Argentina who looked at the single breath count test, which is a principal test of a practice known as spirometry, which is basically measuring the strength of patients' lung function and their ease of breathing. And they wanted to use this single breath count test as a means of providing routine evaluation of respiratory muscle strength. They studied 45 MG patients with varying severities of myasthenia based on their MGFA classification, which is another scoring system that you can use to put a numerical value on the severity of someone's myasthenia. And what they found was that indeed the single breath count test, and by measuring peak expiratory flow, could be used as useful tools to estimate respiratory function in MG. This other machine that I have on the slide is called a niphometer, and it measures another function of spirometry known as negative inspiratory force. This is a measure of how hard someone can inhale against an obstructed airway, and is another method of measuring respiratory function in MG. And I've heard from my colleagues at the EUMGA that this could potentially be another area of great interest that not only could be used for routine measuring of respiratory function in a clinical setting, but also as an early warning system for patients in the comfort of their own home if they may notice differences in their breathing abilities over time, and could hopefully maybe even be a predictor towards crisis. Now, I wanted to finish this section off with a little bit of helpful information. And this is a paper that was published recently. It's a study that took place in the University Hospital in Taiwan. And what they did was they had two groups. They had a test group of 18 patients with MG, and they compared them to a control group of 16 other patients with MG. Now, the group of 18 underwent home-based respiratory muscle training 3 times a week for 12 weeks. Respiratory muscle training involves a series of exercises that can help improve the strength and endurance of your breathing muscles. And it can be anything involving aerobic exercise, such as Pilates, or inhaling against a load, such as what we saw with the Nifometer machine. This study shows that the group who underwent respiratory muscle training displayed improved lung function, and this improvement was significant in patients whose myasthenia was considered moderate to severe. This group also showed an improvement in their 6-minute walking distance compared to the control group and their abilities before starting the 3 months of training. This was a good study for showing that exercises such as Pilates or even strength training with small weights used over a long period of time, little bits, 3 times a week, can help improve respiratory and functional outcomes for patients and reduce fatigue. I hope we're all doing okay. I'm going to take a quick drink because I realize I've been talking a lot. I assure you that we are on the home stretch very much as we turn our attention to bone health and myasthenia. And I know this is an important topic for many of you, particularly in relation to steroids and their impact on patient burden. So with that in mind, let's start with a discussion around steroids and their impact. And I've heard from many patients that the side effects associated with steroids can often be worse than the symptoms of myasthenia itself. Steroids have a profound impact on one's life, and this is something that, as the research and partnerships officer or manager now, that I try and emphasize to external stakeholders whenever I can, that is a significant burden and unmet need for those living with myasthenia, and that more needs to be done to help spare the dosage of steroids or reduce the length of time that one is being treated with steroids. And how do they work to help treat myasthenia? Well, steroids, they work to inhibit or suppress B cells, which, as we discussed earlier, are responsible for producing antibodies. Without antibodies, we don't get the same blockage of receptors, either on the nerve or muscle cell. And in theory, this opens up that channel of communication at the neuromuscular junction once more, reducing the muscular fatigue. They also help to reduce inflammation, which, as we talked about again, is that sort of flag or signal to your body to activate the immune response, dampening down the release of antibodies, and in theory, reducing those symptoms of muscle fatigue. However, as we also know, they come with a whole host of their own problems and side effects, such as weight gain, mood swings, insomnia, and many more. So if we look a little bit at research looking at steroids and their impacts, and specifically unfortunately, this is myasthenia gravis again, and I appreciate that a lot of the research is looking at MG. But as I said at the start of the webinar, it just so happens that this is how research is focusing at the moment. And I'm hoping that with awareness of MG improving, that people start to look more at LIMS and CMS as a response to that. So this study in particular that we're looking at comes from Brazil, and it looks at the negative impact of high cumulative steroids and their impact on bone health in MG patients. They looked at various factors such as low bone mass and osteoporosis in MG patients. And the patients that they looked at had an average dose of 38 mg of steroids and had lived with MG for an average length of around 13.5 years. If we look at this diagram provided by the publication, we see that the bone mineral density being reported through X-ray of an MG patient of the lumbar spine and total body, it shows that there is osteoporosis of the right hip of the patient. And this patient in particular had been diagnosed with MG 1 year previously and was on a cumulative glucocorticoid dose of 41 mg. Now, what this study successfully showed was that patients under high cumulative prednisolone dose presented impairment of bone metabolism, a significantly lower bone mass density in relatively young patients when compared to their peers, and that rising steroid dose negatively correlates with calcium levels and bone mass density. Now, this was the first study of its kind to use this particular type of X-ray to assess bone health in MG patients in this way. And only a few studies previously had evaluated the prevalence of osteoporosis in MG patients so far. A previous study has shown that MG patients present an increased risk of developing osteoporosis compared to the general population, and this occurs regardless of steroid treatment. But those who do take steroids have a more increased risk. And what studies like this do is they point towards a need to evaluate bone density in MG patients, particularly those receiving steroids. So this could also apply to LEMS and CMS patients as part of their treatment and care plan. Now, in that last slide, I briefly mentioned bone mineral density and didn't really get into too much of what it actually means, but I'd like to take a closer look at its role. We have here the term osteopenia. And what this is basically bone density loss. So we can see here in sort of the healthy bone, we've got these sort of smaller pockets within, and these pockets start to grow bigger and thicker as the health of the bone decreases, and we resolve into osteopenia, leading to osteoporosis. And what this means is that the bones can become weaker, and it means that there's an increase in the risk of bone fracture. Now we can see here also in this graph that there is a trend in our bone mass that shows that by the time we reach our 30s or so, we begin to see a natural decrease in the density of our bones, particularly in women due to the menopause. Another great point of the menopause, obviously. But why this is important to note for myasthenia patients is because, as the next study shows, we have a significant difference in two locations, the femoral neck and trochanter, in the bone mass density of those two bits, the skeleton in particular. And that the average bone mineral density, when compared to comparing MG patients to healthy controls, this was a comparison of 86 MG patients who were undergoing steroid treatment with 86 people without MG and without steroid use. We found that there was a significant difference in their bone mineral density at these two sites. Now, for those of us who have maybe not worked in research, this value here called a p-value. This is something that researchers use to define whether or not a numerical change is statistically significant. And basically the lower, the more significant it is. And as you can see here, this p-value for these two numbers is less than 0.001. And it's in italics to represent the fact that this is a statistically significant difference. This 25-OHD, which we'll talk about a little later, relates to vitamin D levels, which we can also see has a statistically significant difference when you compare someone with MG to a member of the general population. Now, speaking of vitamin D, they looked at these levels, and what vitamin D does is it plays a crucial role in maintaining bone mineral density, which, as we've discussed, is really important for bone strength and overall bone health. And what vitamin D does is it helps regulate the levels of calcium and phosphorus in the body. This study showed that vitamin D deficiency and insufficiency were widely prevalent in almost 70 and 23% of MG patients, respectively. Another study also reported that 88% of patients with MG had vitamin D insufficiency or deficiency compared with 62% of healthy controls. And what these results show is that there is certainly room to further understand both how bone mineral density and vitamin D levels in myasthenia patients can help improve outcomes, and how this knowledge can be incorporated into improving care plans and reducing the risk of osteoporosis. Now, the last bit of research that I would like to talk about is a little tool called FRAX. It's a really handy tool that is being utilized by the World Health Organization to assess the risk someone holds of suffering from a bone fracture. And it was actually developed by our very own University of Sheffield. So anybody from Sheffield, there's a little claim to fame for yourselves. And it was released in 2008. And what FRAX does, and this stands for aptly named Fracture Risk Assessment Tool, is it looks at several clinical risk factors and patient demographics to calculate the probability of someone having a fracture over a projected 10-year period. And it's recently been used in myasthenia patients in a few studies. And last year, a 10-year prospective study was published. So this was a study where they followed 28 patients for 10 years. And what happened was at the start of the 10 years, they took this tool, applied this tool to the 28 patients, and they found that those who had a higher FRAX score did indeed suffer from a fracture of some sort over the next 10 years. So when compared to their counterparts who had a lower FRAX score at the start of the 10 years and did not suffer from a fracture. So this highlights a need to measure other clinical parameters when assessing myasthenic bone health. And in turn, also, this study proved that FRAX could potentially be a handy tool for clinicians to use to keep their myasthenia patients informed regarding their risk of fracture. So something to keep in mind maybe the next time you're speaking with your neurologist. Now, very well done to all who have stuck to the end. I greatly appreciate your attention, especially on a Wednesday. This is a little summary slide of some of the key take-home messages that we've discussed. So first off, as I've said throughout, there remains a significant need to better our understanding of lung and bone health in CMS and LEMS. We need more literature out there, more studies that help us better understand. And it's not good enough just to take the conclusions drawn from MG research and apply them to CMS and LEMS. They need specific research that's tailored to those diseases. We also have discussed that MG awareness is improving and that recent studies have highlighted several potential tools that could be applied to modern practices. We also discussed the fact that steroid treatment over a long period of time poses a potential risk to bone health, and that breathing difficulty in myasthenia requires more investigation and research. And I'll finish just on a note. Oh, actually, you know what? I won't finish just on a note. I'm bringing it back to vocab check. So if any of you spot some phrases or words there that now make a lot more sense than they did at the start of the webinar, then very well done to you. If all 7 of them still don't make any sense, then that's totally fair. I will work to improve my science communication. And if you knew all 7 words before we started, fantastic. You can take the next webinar and I will sit this one out. Very well done to you all. So just the last note, just to say again, thank you very much for being here. Thank you for your patience and your listening ears. The next webinar, I'm pleased to say, will be focusing on immunotherapy. And it's my hope to get a guest speaker in for that topic. But failing that, you might have to listen to me again for a little while. But yeah, again, thank you to the listeners and their members, and thank you to the support team.
Thank you, Charlotte. That was certainly very interesting. I'm sure everyone has learned a lot. I know I certainly did. We've seen all of your questions coming in, so thank you for those. If there's anything that you think after this session, then do feel free to email us. And Charlotte, as we mentioned, we'll be reviewing all of those and we'll be sharing the answers with you in the coming weeks. All that is left really for me to say is a very big thank you to Charlotte for your time spent preparing today. And thank you to the support teams, especially Anna, who has been busy working hard behind the scenes and making today possible. And finally, last but not least, thank you to you, all of our members who have joined us this afternoon. Without you, none of this would have been possible. Just a note to say that we've already received a number of donations for this webinar. So big thank you to any amount that you've managed to give, big or small, which means that we can keep running these events for you. And there is still time to donate if you're able to, of course, via the QR code or on the website as normal. A feedback survey will be making its way to you shortly. So if you do have time to let us know your thoughts, please do so. It helps us keep delivering the webinars that benefit you, our lovely members, and we always love to hear from you as well. So thank you, everyone. Have a wonderful rest of the day or morning or evening, depending where you are in the world, or perhaps you're watching this back. I'm sure we will see you again soon. Goodbye, and thank you for joining us.